Thank you. Thank you. Good morning, everyone. I'm so excited to have such a full room. I'm getting nervous, but we'll get started. This is my first time here in Connecticut, and it is beautiful here. This was a great time of year for y'all to have this. I love seeing all the colors. We don't get to see that in Texas. We see brown. That's because the leaves are burning. But it's such a pleasure to get us started today. We have a great lineup. I want to thank everyone for coming, and I want to thank Leah and her team for having this grand event. It's been wonderful. And we want to thank OR today also. So since I'm getting started, I do want to say this is a challenging topic, implicit bias. But this is a crucial subject because it impacts patient care and their outcomes. Okay, let me see if I can work the clicker. First, let me tell you that I do not have any conflicts of interest or any closure or any disclosures, but I do have implicit bias. So let me apologize now if I offend anyone because it is not my intention. My intention is to make you more aware of what implicit bias is and how it could make effect on patient care. And just to provide you with a little education. You already heard that I'm the president-elect of AORN. I'm so excited. For 2025 and 2026 will be a great year. I am just elated with this opportunity to serve you all. I want to thank all of you for your continued support on my AORN journey. I'm also a staff nurse at one of the busiest level 1 trauma centers in the nation, and it's in Houston, Texas. And Houston, Texas is one of the most diverse cities in the nation. But let me tell you, as a nurse, as a Black nurse, as a member of a profession that is mainly of white females, there has been many times I have been mistaken as the cleaning help. And there has been many times when I'm shopping in Walmart that I have been mistaken as a Walmart employee, even though I'm dressed in street clothes, purse in hand, and sometimes a shopping cart. But this is not uncommon because 75% of Black people say that they experience microaggressions daily. Daily, that is. Microaggressions are subtle or nonverbal insults, and they are a byproduct of implicit bias. When I first started my career as a nurse, people will ask me, well, what do you do? And I would say, I'm a nurse. And they would say, a nurse? A registered nurse? And I would say, yeah, I'm a registered nurse. I went to nursing school, passed my classes, and graduated, did everything else. I'm a nurse, a registered nurse. But it seems like they were surprised that I was a nurse. So I want to ask y'all, have you ever been in a conversation and walked away and said, was that a compliment or was that an insult? I think we've all had those moments. Well, that was probably a microaggression you experienced. Like I said, microaggressions are a byproduct of implicit bias. It's unconscious attitudes, association, and beliefs about a group of people, commonly known as stereotyping. It leads to behaviors and actions in favor of or against an individual or a group of people opposed to another. It is automatic and unintentional, meaning you are unaware of your actions or your feelings. It is human nature to be judgmental and have preferences. We all prefer to be around people who look like us. As they say, birds of a feather flock together. How many of y'all remember that saying? Well, that's called affinity bias. Let me see if I can work this. That's called affinity bias, favoring people who look like us or have the same interests, background, or experiences. Our life encounters, exposures, and experience have an influence on how we think. Even as babies, we develop preferences. What we see in the media, what we see and hear our parents and our family members say and do all have a powerful influence on the behavior and the actions, even when we are providing care. What's troubling about implicit bias is that it may not align with one's values. And that's why many people are emphatic about saying that they don't have implicit bias. Most people are unaware of how deep their biases run and don't know that at times they are displaying discriminatory behavior. Do you remember during the pandemic, or George Floyd's death? When he died, a lot of people were saying, I'm not a racist. I have Black friends. And Black people were going, what are they talking about? They just displayed discriminatory behavior the other day. So I think a lot of people just don't know that they're displaying discriminatory behavior. So that's what we're going to talk about this morning, implicit bias. And I hope to raise your awareness about implicit bias because research shows that it affects the care we provide. And I also want to show some strategies to help diminish the effects of implicit bias. Now, don't think that after this session, you'll be cured of implicit bias. That is not going to happen. But it will give you some strategies on how to work on it because it's like losing weight. How many of y'all have tried to lose weight? It's hard. It's a journey. You got to keep working at it or the pounds will come back. So the name of this presentation is What Can You Do to Diminish Implicit Bias? Because as a healthcare professional, it is your personal and professional choice. You can't really eliminate it, but you can manage it and mitigate it. You could also put policies and procedures in place at your organization to help mitigate the effects of implicit bias and promote health equity. Now, health equity is the absence of unfamiliar, unavoidable, or remedial differences in health outcomes among groups of people. And that's according to the World Health Organization. Now, health equity is a measure of quality of care. As a matter of fact, the Joint Commission is addressing health equity as a quality and safety priority for the first time this year, and it is listed as a national patient safety goal. Did everybody already know that? I hope so. Okay, good. So let's pause here and find out a little bit about our audience. I hear we have quite a group of different people with different roles. So show of hand, how many staff nurses do we have? Okay, great. How many nurse executives? Oh, we have some of those too. Welcome. Thank you for being here. Coordinators. Okay, managers. lots of managers, scrub techs. Oh, great to have y'all here. Surgical tech, I'm sorry. I stand corrected. Surgical technologists. We're glad to have you here also. We're always glad to have surgical technologists at AORN meetings. And how many have another role?
Anesthesia care unit.
Okay, great. Anesthesia care. Did I hear something else? SPD? Nurse scientist. Wow. Educator. How did I forget that one? Okay, great. Any other professions? Okay, well, great. It's so good to have all of y'all in one room. This is rare, isn't it? Well, thank y'all so much. Well, I think everybody kind of knows what a circulator does, right? Kind of. So I want you to, just for a minute, imagine that you are a circulator. You are the circulator and it's right at shift change. You know, it's a 12-hour shift and you got about 2.5 more hours to go. And it's been a typical day in the OR, late surgeons, slow surgeons, anesthesia dragging their feet, case shuffling, missing supplies, hunting down equipment, answering beepers and phones. That's my favorite. Consent problems, reconciling incorrect counts, and then you go to the break room, you sit down, you slide off them shoes because them toes are tired. And bam, you get a call. You got an urgent case. Doggone it. Okay, so you get the case started and you sit down and start your paperwork because you want everything done because you want to run out of there when your relief comes. So in walks a young white female. What do you think her role is? Real quickly, right off the bat. Anybody, what do you think her role is? You think she's the nurse? Med student?
I'm hoping she's my relief.
Okay. Okay, so how many initial thought is that she's your relief? The nurse. Okay, great. Why not the surgeon? uh, she's on time and early. You're right. You're right. Well, before the promotion of DEI, most pictures we saw anywhere of a nurse was a young white female when the average age of a nurse is over 40. So the image of a nurse as a young white female has been embedded in our subconscious, even to mine as a Black nurse. So another question real quick. What if a Black female walks into the OR? What's your initial thought? You still hoping she's your relief? Scrub tech, maybe?
The other thought that came to my mind was that if I'm running a room, I know most of my surgeons that I'm going to be working with for the day, so I know what they look like. I know what my anesthesia care providers look like. So I would be expecting it to be my oncoming shift.
I thought about that too, but I work in the level 1 trauma center and it could be anybody. And I work the night shift, so
Yeah.
I don't know all the nurses. And we get new nurses all the time.
I'm a traveler. A lot of hospitals like to do are travel heavy. I don't even know half the travelers.
You're right. So I tell you what, there's not many Black nurses And so you probably wouldn't think it was a black nurse. Would you think it might be a black female surgeon? I tell you, in my 30-year career, I think I've only seen 3 black surgeons, only 3. She's seen 2. Okay, so what if a middle-aged white man walks into your room? It's not Bill Duffy. So what would you think? What would you think? Anesthesia? Well, I tell you, the internet, if you Google doctor on the internet, a white middle-aged man will come up. So that has also been embedded in your brain. What about if an Asian male walks into the room? What would you think? Anesthesia or neurosurgery. That's correct. You wanted the 2. And so what is your thought if a black male walks into the OR? What's your initial thought? Ortho what? Ortho surgeon.
And they're tall.
They're tall, they're big men, you're right. Well, even at my facility, if a black male walks into the room, it's probably be hard to think what he would be because there's not many black males in healthcare at all. I was surprised to learn that. I knew there was very few doctors, black doctors, but any black male at all. And what if a Hispanic woman walks into the room? What would you think? Well, there's not many Hispanic RNs either. Even at my facility, we are a diverse city, large Hispanic population. We don't have many Hispanic nurses. Well, these are all called perception bias. We tend to form stereotypes and assumptions about groups of people. So how many agree that they have perception bias? Most definitely. So we put our coworkers in a box according to race, age, and gender. Not only do we put our team members, we also put our patients. We have perception of our patients. How many of us go out and before you go out, you look at your patient's name and age. That's what we've been taught to do. But when we do that, are we setting up our perceptions in our mind? Have you ever went out to go look for your patient and you're looking and looking, but it's not the one you think it is? Yes, I've done that too. So here are some more examples of perception. Well, I've already talked about that. Perception bias. But there are many other types of bias, and there is a list of, this is a list of common biases. Oh my. I've already touched base on affinity bias, favoring people who look like us or have the same background, interests, or so on and so forth. But affinity bias has an effect on hiring practices. Everyone looks the same and have the same attributes or characteristics. Okay, I can't get my, oh, there it goes. I'm sorry. But even at my facility, we work in pods. And we had 2 pods, like she said, the neuro pod, who had the Asian surgeon, had more Asian nurses. And then our orthopod had more white nurses. So you could get into that affinity bias in hiring your team members, because we interview each pod, get to interview everyone. So you end up with people who look like you and think like you, and you're all the same. But research also shows that white sounding names are more likely to receive job interviews. That's called name bias. Black students are suspended and expelled 3 times more than white students and are more likely to be referred to law enforcement. This is called confirmation bias, that all Black people are violent criminals and are treated as such. Teachers have lower expectation of students with disabilities than those who do not, and that's disability or ability bias. So does anybody have any of these biases? I definitely have the name bias. So what can you do if you have these biases? Going back to an old saying, don't judge a book by its cover. Remember that? I hadn't heard that in a while. Our first impressions and snap judgments are not always right. For name bias, when looking to add new team members, I know I've done this, they take the names and the pictures off of everything so that you can really focus on their qualifications. When I updated my resume, I was advised to leave some dates off so that they couldn't figure out what my age was. I was happy to do that too. So what you can do is think twice before dismissing someone. Double check your initial thoughts, especially when it comes to perception bias, because as you saw before, we all have them. We all have some of the same biases because we work in the same environment. So do you have implicit bias? Yes, you have. You sure you do. We all do. If you're human, you have implicit bias. It doesn't mean that you're a bad person or racist. It just means you're human. And I think most of us here, like I said before, have some of the same biases because we work in the same kind of environment. So let me tell you about my implicit bias. I was the nurse who was getting relieved during an emergency case at shift change. A young white female walks into the room, and I said to her, full of joy and happiness, "Good morning, how are you? Are you my relief?" And she politely said, "No, I'm one of the staff surgeons who will be working on this case." And of course, I apologized immediately, but the damage had already been done. I imagined at that point how many times she had been mistaken as the nurse instead of the doctor. Probably more times than I've been mistaken as the cleaning help. I knew exactly how she felt, and it's not a good feeling at all. So I pondered, do people feel as bad as I did at that moment when they mistake me for the cleaning help? Probably. Then I thought about it. I'm like, I was just so ready to go. I couldn't see what she had on. I couldn't take the time to read her badge. I was just ready to go. And I thought about the people in Walmart. They're so frustrated they can't find what they want or what they're looking for. They don't see what I have on. They just see help. So we need to be mindful of these things because it's hurtful. So without our conscious knowledge, implicit bias has a profound effect on our behavior and our decision making throughout our daily and professional lives. You just can't check your implicit bias at the door, especially if you don't know you have them. Research indicates that healthcare providers' implicit bias affects the care we provide, and that contributes to health disparities. Health disparities um, are health disparities mean that there's differences in the incidence, the prevalence, mortality, and the burden of diseases and other adverse conditions that exist among specific groups in the U.S. That means there are gaps in healthcare for many. A whole lot of folks, including children, are receiving a lower quality of healthcare just because of their personal characteristics, such as their gender, their skin color, sexual orientation, and that's just to name a few. And that's when insurance, income, age, and severity of conditions are similar to their white counterparts. For example, during the pandemic, people of color had higher rates of infection, hospitalization, and death due to COVID-19. And as you can see here on the slide, Blacks have the highest incidence of hospitalization and deaths, which is significant because Blacks only make up 14% of the US population. So I think the pandemic really brought to the forefront health disparities. And I think a lot of people think that this was the first time health disparities was brought to the forefront. But in 1985, the Heckless Report showed that minorities carried a much higher burden of death and illness than whites. And then 20 years later, in 2003, the IOM, now known as the National Academy of Medicine Institute, released their report acknowledging that health disparities in America still exist. Now, when I read the report, it seems like they were surprised at their findings. But it's true, health disparities still exist in 2003. Now, that was about 20 years ago, and research still indicates that health disparities exist, and clinician implicit bias contributes to health disparities. Some research suggests that the gap in health of people of color has expanded due to the impact of the pandemic. But for sure, the gap is persistent and perpetuates a lack of confidence in our healthcare system, especially by people of color. So why do health disparities exist? Because they are preventable. Well, it's very complex and it seems to affect those who are already socially disadvantaged. The root causes lie in social and economic factors that are intertwined and interwoven. But research shows that social determinants of health, our healthcare system, and clinician bias are proven contributors to health disparities. Now, how many of you in nursing school learned about social determinants of health? Okay, that's quite a few. When I went to nursing school, we didn't learn about social determinants of health. I didn't learn about it until I got my master's. But there are conditions related to where individuals live, learn, work, and play that affect their health and quality of life and increases health risks. Here are some examples of social determinants of health. I hear health insurance is the big one. If you don't have health insurance, you know, our healthcare system is very expensive. During the pandemic, I can remember my son turned 26 and he didn't have a job. It was scary. I'm like, don't go nowhere. So let's look at our healthcare system. Our healthcare system lacks diversity and policies and procedures. As I stated before, there's not many Black males in healthcare at all, and not many Black doctors at all. And then RNs. Now, we have improved quite a bit with the diversity in our RN pool, but the rate that America is diversifying, we're not able to quite keep up. Presently, 40% of the US population is diverse, but it is projected to become, the minorities are projected to become the majority by 2045. That's really not that far, is that? 15 years from now. Our healthcare system lacks policies and procedures that standardize care. Organizations need to have established leaders that will help standardize structures and process to detect and address healthcare disparities. Research indicates that ERAS, enhanced recovery after surgery, can help eliminate implicit bias by strategically standardizing care. How many facilities here uses ERAS already? Okay, great. That's more than I thought. It's a growing trend and a good growing trend, but it ensures the best evidence-based care for all patients. It includes patient education, early ambulation, optimizing nutrition, and pain control. Now, my facility uses it also, but only for 2 service lines. Just think if it's used on all service lines, what big of a difference that can make. Well, ERAS is proven to decrease racial disparities, decrease length of stay, mortality, readmissions, and post-op complications. So let's try to do a patient scenario. We have a patient here. She's a 57-year-old Vietnamese female. She speaks some English. She has abdominal pain with changes in bowel habits. She hasn't had a bowel movement in about 2 weeks, but she is passing. She has insurance, but she had to scrape up to $40 to pay her copayment. She uses public transportation, and about 20 years ago, her mother died of colon cancer. So she goes to see Dr. Mark Smith, and he's male, of course. He's 65 years old, and as usual, we all know their offices are always overbooked. His wife was talking divorce last night, and he has implicit bias. His implicit bias includes that against illegal immigrants. Not saying that she's illegal, but that's what his implicit bias is. Thank you, dear. So he asked the patient, "Do you speak good English?" And she nods yes. So he does not get a translator. Did y'all catch that? That's a microaggression. He doesn't complete the H&P. He overlooks the patient's family cancer history because he doesn't quite understand what she says. He recommends that she take a mild laxative, increase her diet with water and fresh vegetables, and return in 2 weeks for a follow-up. He doesn't do any tests, no tests at all. Not even blood work for baseline. And then after 2 weeks, and when she doesn't return, he doesn't follow up. The patient felt rushed. She did not understand all the terminology. She felt like her mother was right. Doctors don't care. Her abdominal pain becomes unbearable, and then rectal bleeding is noted, and she's diagnosed with colon cancer 6 months later. So what are some of Ms. Tran's social determinants of health? Anybody want to guess? Do I need to go back to that slide with this? She had insurance, but she didn't have the money to pay the copay. So language barrier for sure. She had transportation problems. problems, income. Someone said health literacy. I think that's the word I'm looking for. And she prefers to have a Vietnamese healthcare provider, but there's not one in her neighborhood. Yeah, okay, great.
So on the reverse side, if I was the patient and they asked if I spoke good English, whether I did or not, I would say yes, but I would prefer a translator for discussing consent forms and medical technology.
Not everybody does that,
Not everybody knows.
and not everybody
And
knows.
I've found some hospitals, instead of just asking if they understand English, ask if they would prefer a translator also, like it's part of their.
But this is in a doctor's office. This guy's in a hurry. He doesn't care too much about Vietnamese. Yes, ma'am.
I found in my own experience, not with me, but with my family members, that, yeah, they spoke English. They didn't understand a darn thing that the doctor said.
Right, right.
And the God complex, it's another implicit bias
Mhm.
in patients, that this man is supposed to know everything and I don't want to bother him or take up his time. So that also impacts your own personal health care.
Correct. I know I went out to interview patients and I asked them what their name is. They'll say their name, their date of birth, and then you ask them something else and they don't know what you said. They shake their head. Yes, sir.
Cultural background also affects this coming from Southeast Asia. If you would understand what Southeast Asians are, we tend to be more not too assertive about if a doctor says so, the doctor says so. That's at least for those that were born and raised in Southeast Asia, not if you are born and raised here where you are taught to be assertive.
Right. Okay, great. Great discussion. Anybody else? Okay, so what are Dr. Smith's implicit bias? Somebody already said God complex. What about her name? Name bias. He saw the foreign name, and the first thing he asked her was, do you speak good English? What about her gender? Did y'all know women's, a lot of doctors ignore when they say they have pain?
Yes.
I didn't know. They've said it's at epidemic proportions. I didn't know that. I knew it happened, but I didn't know it was at epidemic proportions. But yeah. What about her age? Was she 57? Colon cancer, I think, usually starts after the age of 60. So that's another reason why he dismissed it. Okay, what was some of Miss Tran's implicit bias? I think we kind of said some of her culture, background, confirmation bias. Remember, she said mother was right? Yeah. Okay. So does everybody kind of see what social determinants of health and implicit bias does? So implicit bias can lead to inaccurate assessments. And if you do an inaccurate assessment, what does that lead to? Inappropriate diagnosis and treatment. And care, yeah. Decrease involvement in the patient care. I've seen nurses who, they go see the patient, they ask them 5 questions, they don't go back and ask anything else. There's some patients who get discharged without the follow-up. There's research that show that some, even nurses, show decreased compassion for their patients and decreased effort for a therapeutic relationship. How can you have a, patient-centered care if you don't have a therapeutic relationship with your patient? It's got to go hand in hand. So what can you do to diminish implicit bias? That's our question. The first step is self-awareness. I hope I made some of y'all aware because I was made aware when I called the doctor or nurse. I thought I need to check myself. But we need to acknowledge that implicit bias exists. A lot of people do not want to acknowledge that they have it. But once you find out what your implicit bias are, then you can really work on them. One way to find out is the implicit association test. A lot of people, this is the Harvard test, if anybody wants to scan the code. But these tests tell you where your biases lie. They're not to see how much of a racist you are. I heard that before. But you don't have to tell nobody you took the test. But it helps you find out what your hidden perceptions are, your attitudes, and things that are in your memory. So I say at least just take the test. There's some people recommend that you take more than one test. There's some people say that the test is not accurate, but I think it'll give you an idea at least where to start. But we've got to be honest with ourselves for our personal and professional development. So here are some things you can do. Actively listen. Answer all your patients' questions. I know we're in a hurry, first case starts and all of that, but answer all their questions. Educate your patient, advocate, and remember the nursing code of ethics. When I say actively listen, I mean listen differently. Listen to understand and not to respond. Listen with your heart. Listen with empathy. Interpret the verbal and nonverbal cues. There's a quote that says, to listen with empathy is the most important human skill. And I think that's a very important skill that nurses should have. Listening is a form of respect. A lot of patients of color said they have received disrespectful care. I am just so surprised at that. That's like kicking somebody when they're already down. How can you be disrespectful with someone who's already not feeling well? So people of color have higher incidence of experiencing stressful, unpleasant, or disrespectful health care. 70% of the LGBTQIA plus community state that they endure discrimination when seeking health care. They're humans. They're humans. Work to overcome language barriers. Call for the translator. We all got these little machines now. They're easy to work. Even I can work them. But we got to find a way to communicate with our patients and answer all their questions. Educate. That's the fundamental thing that a nurse does. We only have a few minutes with our patients, but we could take a little time out to educate them. Make sure they're making an informed decision. It's proven that when you educate your patient, it reduces their anxiety. And then educate each other. Educate each other about your culture. I'm so glad the young man back there spoke up about his culture. We would have never known that. And then increase health literacy. Health literacy is another problem for causing health disparities. As you saw in the little skit we did, that the lady did not understand. So we could take the time out to make sure, assess our patients, does she really understand what a laparotomy means? It only takes a minute. And then advocate. Advocate for diversity, equity, inclusion. All these initiatives. Then standardize procedures and protocol. ERAS. Like I said, we only have 2 at our hospital. Just think, we're a level 1 trauma center. If we use more ERAS, how much of a difference would that make in patient care outcomes? AORN will soon be coming out with an ERAS position statement. Is it a position statement, JD? Yeah, position statement. So we will learn more about ERAS. It's kind of new for a lot of people, but we're getting ready to find out. And I think it's a very good thing. And do screening for social determinants of health. We can do that real quickly at the bedside. Someone picking you up. Do you have something to eat when you get home from your surgery? And then data collection. We've got to be collecting the data concerning diversity, equity, and inclusion. Is my time up? Okay, good. And then legislation, we got to get involved. I hope AORN gets more involved with legislation concerning health equity. We'll see in my year. And of course, we got to remember to follow our nursing code of ethics. What does it say? That the nurse practice with compassion and respect for the inherent dignity, worth, and unique attributes of every person. Provision 8 says the nurse collaborates with other health professionals, and we got a lot in here today, and the public to protect human rights, promote health diplomacy, and reduce health disparities. So do surgical patients have disparities? Yes, they do. People of color are less likely offered surgical intervention. They lack timely follow-up. They have increased adverse events, increased length of stay, increased readmissions, decreased patient satisfaction, and variations in care. That's why it's important for us to have ERAS. So no one, I believe, has a mindset to purposely provide substandard care. I choose to believe that. But research confirms that health professionals do stereotype their patient, which leads to providing substandard care. There has been over 40 years of research confirming health disparities. We haven't come up with a solution. But as nurses, we could take the responsibility and work on our own implicit bias. We believe we are treating everyone the same, but research shows that we are not. So become aware of your implicit bias and move forward to diminish their effects. Move forward with great intentions. If you are human, you have implicit bias. Listen to your patients. Advocate for them. Advocate for standardized care. Educate them. Abide by the Nursing Code of Ethics and do your part in helping to promote health equity at all levels. That was the heavy subject. I just want to make you smile.